So I was here at the AAE meeting, and as you can see, there's some residents playing ping pong behind us. And I'm joined by Dr. Shervin Goli. And Shervin, thanks for joining me.
Thank you for having me here, Ali.
All right, so Shervin had a case that shared with me right before a talk that I gave here at the AAE, and I actually incorporated the case into the talk because I thought it was so important. And actually, he has the case right now on his phone, and it'd be awesome, Shervin, if you can just share with us the case and what you saw in there that was of significance.
Yeah, I mean, literally, this is a case that walked into my office last week, so we didn't really formally get to present it, and we put it into the presentation just via my cell phone, and it worked out brilliantly. But I had a case that I did 2 years ago. It was tooth number 12 with extensive caries to the pulp. The patient was symptomatic, so it was irreversible pulpitis with a carious pulp exposure. The pulp was vital, there was no lesion at the end of the apex, so we just treated it as a conventional root canal therapy, removed the caries, and obviously got a pulp exposure. So what we did next is rubber dam isolation, take a working length film.
Now, what I like about what you did over there, Shervin, is that you put the clamp on the tooth behind the tooth, on the second premolar. So that allowed you to kind of pull the rubber dam over so you could actually see the full margin of the decay so that you could remove all of the decay, correct?
Exactly, yeah. I do a split dam technique. If there's a tooth behind the one I can isolate, I rarely ever isolate on that specific tooth because it gives me the ability to actually see all the caries and make sure it's restorable. And my referring dentists really rely on my ability to determine whether a tooth is restorable or not. So.
I think what you just said there is critical because a lot of times people just remove enough decay so they can do the procedure. They kind of say that if I remove all the decay, then there's going to be a problem with the leakage going on. But the key here is to remove all the decay so that you can make sure the tooth is restorable, or if it requires crown lengthening or any other additional procedures. So the patient should be aware of these things before you go ahead and do the root canal procedure so that it doesn't become a surprise cost or an additional step to them after the root canal has been done. So I think it's the role of the endodontist to completely remove the decay and then establish restorability and whether there is something else needed to be done. I'm sorry to interrupt. Go ahead.
No, in fact, you hit on a really good point because especially in this case here, as we're going to see as we progress, the coronal seal is going to be very important in determining what happened with a sealer in this case. In my office, we advocate for me removing all the caries, and I do the build-ups. If it needs a post, I place the post because we really want to make sure to get that coronal seal to get the best success for the patients. And I think that's really a good point in this case especially.
So I can see that you really got very nice lengths. It's right to the point here. You use an apex locator to do that?
I do. I confirm with the radiographs afterwards just because I want to make sure that our apex locator is right on, and having two sources of information is sometimes better than just having one source, even though apex locators have been shown to be 95-97% successful and accurate. This is a good way to just confirm.
Of course, you don't want to be in the 5% where it's not accurate. Therefore, having the radiograph helps. And also the other thing that I always mention on the channel here is that having the x-ray helps you understand any kind of apical anatomy that may be present that you can't see. I mean, the apex locator is not going to tell you anything about apical anatomy. And that apical anatomy is significant and important in terms of determining your master file. So if you have a big hook at the end of the root, you need to know that at this point so that you can determine what apical diameter you're going to finish this tooth to. If you had a big 90-degree curve, you're not going to go to a size, 45, obviously.
Exactly.
So
yeah. It helps you read the anatomy. I mean, this was done 2 years ago. It was 24 months ago that this was completed, and I didn't have the cone beam at the time. And we don't take cone beams on every case, but with a cone beam, you can definitely see some of those curvatures before you get into it. In this case, the file is going to actually show me that this is going to be my three-dimensional anatomy that once I take that file shot. So.
Okay, so then you go ahead and do your full instrumentation, and at this point you're ready to fit your master cones in there, and you got your cones all the way to the end, and you're ready to do. So this is from a couple of years ago before you were using hydraulic condensation. So you were at that point using, what were you using?
At that point, I was using warm vertical obturation, continuous wave with AH plus sealer. In this case, actually, with the cone shot, another reason why we take a cone shot is we also want to reconfirm after we've instrumented how far we've gone. And even though I've been doing endo for about 15 years, you can even see in this case, it looks like it was the buccal root. I'm a couple of millimeters short. And lengths do change once you start instrumenting to larger sizes. So it's very important to go back in and check it. And I saw I was a little bit short, so I think I went back through and re-instrumented a little bit more. And as we'll continue on, I think we'll see.
So you reestablished length, and I can see you did a beautiful job with the vertical condensation and placed the post immediately thereafter and put a core buildup in the tooth. This is your immediate post-op X-ray, correct?
Correct, right.
Yeah.
This is our immediate post-op X-ray, and this is where endodontist or anyone who loves doing endo gets the thrill of the fill. You're so excited to see this. It looks like fireworks of the 4th of July. And you're looking at all these portals of exit, and you see these sealer puffs, and it makes you so happy. You're so proud that you did this. Yeah. And when you send the patient,
I believe I described it yesterday in the lecture as an orgasmic radiograph.
That's
right?
Right. Yes, you said, "Give me more, give me more." So I do wish every case would look like this, because you're so happy to see that not only one that you filled everything, but this also speaks about your irrigation beforehand, and the irrigation protocol is really important in order to be able to open up these actual pathways of exit, so these portals.
Yeah. So beautiful fill here. This is you filled vertical condensation using a resin sealer. This is H plus at a higher magnification. You can see all the fireworks, correct? Now, in the post-op X-ray, you can also see that there's the beginning of some interproximal decay in the adjacent tooth in the mesial area of the second premolar,
right,
which oftentimes is the case where you have a large carious lesion in one tooth, and approximately the opposite side of the other tooth would have some carious involvement. And you, from what you told me, you described this to the patient that treatment caries control as well as a filling is required in the adjacent tooth.
Correct.
But this patient was unfortunately not so compliant,
right,
and ended up coming back to you in 2 years for a root canal on the adjacent tooth. So now the caries had enlarged dramatically. And not only we see now this enlargement in the caries on the adjacent tooth in the second premolar, but we also get a chance to do a recall on the first premolar. And I think the most significant thing that you find is what?
Well, the most significant thing was not only was I disappointed that the patient didn't go through and follow through with caries removal on the other teeth, I looked at the tooth that I treated, and in 24 months, what we see is, where's all the sealer? Where are all the sealer?
Where are the fireworks? The fireworks are gone.
Go? So, and this is what's concerning about situations like this is all the sealers up until the BC sealers that we've been using, it doesn't matter which endodontist use what sealer, they all will resorb. And some to some degree, some to another degree, but if there's a way for the body to actually reach that sealer, it's going to start resorbing it as if it was external to the root.
Yeah. So basically the lesson here is that it's great to get all those fireworks, lateral canals, and so on with your hydraulics, but if you end up using a resorbable sealer, then all you're getting is basically you're getting a result at a moment in time, right at the post-op X-ray, because all that stuff is going to be gone in time if it's resorbable. And that is really the idea of why sealers should not be resorbable, because of the fact that, while your cases may look beautiful at the time that they're done, a little bit later they will be all gone. And oftentimes people talk about using ZOE with silver particles in it. And in those cases, the ZOE will be gone, the silver particles remain and give you the impression that the sealer is still there.
Correct.
But it's actually not the sealer, it's just silver particles.
Exactly. And I think, and this brings us back to the beginning of what we were talking about is, why is it that all the studies that we do in endo showed that the coronal seal is the most important seal? Is because we know that if this tooth didn't have the crown immediately, not only would we get wash out of the sealer at the apex, we get wash out of the sealer in the entire root canal system. So then you're just left with cones floating or gutta percha floating inside the tooth. So I think this reemphasizes the point of coronal seal is very important. And so what do we do about our sealer?
Yeah.
And this is where the BC sealer, I think, really addresses an issue. And people say, well, root canals are 95%, 97% successful, so why do we need to worry about this? Well, I think we need to worry about it is because as human beings, we're always trying to do better. And even a 3% success rate, if we can improve on that, the failure rate, we can improve on that. It's better for us. So.
Hey, that's the Kaizen philosophy. There's always improvement, and there's really no limit into how good. I think until we have 100% success rate, and in my opinion, the real success rate is in trying to avoid having to do root canal therapy. If there's a way that we can somehow cure the need for it, that would be when we actually have improved enough to the point where we've achieved our goal. I think in any healthcare field, the goal of the healthcare provider really is to put him or herself out of business. Let's face the facts here. I mean, I go in life hoping that my cardiologist is not thinking that hopefully there's never going to be a cure to heart disease. So I think that's really the right attitude in healthcare, is to try to find cure to diseases. So this is a really good case, and we can see here at higher magnification again the fact that the sealer is all washed out. And anything else you want to add?
Yeah, now, we can go to the cone beam on this, and I did take a cone beam because now I have that technology in the office, and it's going to actually help me because tooth number 13 and number 15 are both going to need root canal therapy. Number 15, the anatomy is a little complicated, so since we're in there, it kind of helps us with the post-op on this also to see, is there an actual lesion associated with this tooth number 12 when we're going to use the cone beam for our future treatment. And the sagittal view and the coronal view, when you're actually able to separate the roots and see them at different angles, what you do see is that we still have really nice bone all around the roots. It's a completely healed tooth, and I think that goes back to our 95%, 97% success rates in endodontics. It really goes back to eliminating bacteria or preventing bacterial contamination when we're doing treatment, and I think that's why this case succeeds. But in a case like this, had it been a necrotic tooth, had there been bacteria already inside that root canal space, maybe we wouldn't have the same result. Because when the sealer washes out, there's possibility that maybe there was some bacteria that remain in those tiny little crevices, and they're going to slowly overpopulate. So.
I mean, that's really the wisdom of having the non-resorbable material there that the seal maintains in the long run. So this is really educational. Of course, goes back to the idea of fundamentals, which is cleaning, disinfection, and so on, and treating biology rather than treating x-rays. So that really is the full lesson from this. Shervin, thank you so much for spending the time with me. I know you're busy walking around here. It's been a really successful and a nice AAE. Lots of activities going on, lots of educational courses, and thanks again for spending your time with me.
Thank you for having me on Real World Endo, and many more videos and education to come from us. Yeah.
Terrific. For Real World Endo, I'm Ali Nasseh.
Dr. Shervin Golian.
And we hope you found this information helpful.